very much. So the topic of this my talk is primary central nervous system lymphoma. That is, they are quite rare tumors, but they are rising in numbers in our fields. For the one, I have no disclosure, for the one that dedicate to neuroradiology. So Professor Usri talked about the classification of tumors, and you may see here that, oh, it's not advancing. It's not advancing there, as it happened before. Okay, perfect, thank you so much. So Professor Usri talked to us about the classification of tumors, and you may see here that within the classification of the fifth one that we heard about, I'm using the mouse, so among the central nervous system tumors, there are also hematolymphoid tumors that involve the CNS. And among them are lymphoma and histiocytic tumors. These are interesting also for differential diagnosis. CNS lymphoma, as you may see here, are around 7% nowadays among CNS malignant tumors. And you may see here on the right, they include basically, their most important are the primary diffuse large B-cell lymphoma of the CNS. Then we have immunodeficiency, so the Epstein-Barr virus positive cases in immunocompromised patients, few cases of lymphomatoid granulomatosis, and the intravascular B-cell, large B-cell lymphoma. Then we may have some so-called miscellaneous rare lymphomas of the CNS, and among them, to be remembered, are the multiple lymphoma of the dura, and I'll show you one case, and also the T-cell lymphoma, so different kind of cells. I always try to look at pathology to understand the images. So as we'll see later that the major diagnostic differential diagnosis between primary central nervous system lymphoma and other pathologies are with GBM and inflammatory lesions in general, such as vasculitis. If we look at the histology, you may see here that in lymphoma you have almost normal vessels, so in size, and a lot of tiny cells surrounding the vessels. In GBM, and so these kind of cells are basically around the vessels. They interfere with the blood-brain barrier permeability, and they go into the interstitium, the ependyma, the meninges. GBM is different since we have large anomalous vessels, and we have a sort of, I'm sorry, I would like to use that, but I can't, yes. I can't arrive, I think, there, but it's very sensitive as usual, this, so if I, thank you so much. Thank you, okay. So, sorry for that. In GBM, the situation, histology situation is different. We have a very large anomalous vessels, tumor cell proliferation with a sort of, we have heard before, anaplastic cells, so they are also different among them. In vasculitis, we have a sort of more similar to the lymphomas assessment. So we have vessels and a lot of cells surrounding the vessels, and with a perivascular distribution. So keep it in mind. According to the characteristic of the lymphoma, quite recently on neuro-oncology have been published some recommendation on the imaging, and that took care of the presence of these dense cells that appear hypointense in T2, the presence of edema, so the vasogenic edema, then the high but not so high perfusion in DSC, the presence of these numerous cells, tiny cells that create a lowering in the ADC and diffusion. As I told you, the breakdown of the blood-brain barrier permeability, so the high homogeneous enhancement, the permeability, so the use of DCE, the other perfusion, T1 perfusion, and the K-trans, that is a marker of permeability, and of course, but it's not part of the real protocol, as you may see here, the diffusion, the DTI, the use of DTI that may show you the infiltration of the tumor. And if you noticed here in the recommendation protocol, you may see that there is a sort of a recommendation looking at the contrast enhancement when it is injected to go for delay imaging. And I'll show you some cases and the importance of that. So talking about the most important lymphoma, that is the B-cell lymphoma, Epstein-Barr negative, so in immunocompetent patients. There are around 80–85% of all the primary central system lymphoma. The brain location is the most important, but you have to take in mind that you may find it in spinal cord, meninges, and cranial nerves. In most of the cases, they are lobar. They may be also deep in the deep basal ganglia or the posterior fossa. They may have a spread in the periventricular ependymal. In most of the cases, they are single, but they may be multiple. And here on the right side, you may see some examples of these different locations. So we have to look at the MR characteristics. So taking into account the site, as listed here, the lesion morphology, the structure, so that is for us in MR related to signal and the components of the lesion, the contrast enhanced characteristics, and the presence of edema. So relating to the structure, the most typical lymphoma B cells of the CNS has numerous cells, so it's homogeneous in most of the sequences. It's a little bit hypointense in T2. Most importantly, diffusion and ADC is restricted, and it has a relationship with the high cellularity, as you may see here. The enhancement, as I told you before, is very homogeneous in most of the cases and intensive. Look here, the major, one of the possible differential diagnosis with GBM in the same location of the splenium of the corpus callosum. You see how GBM is more inhomogeneous, and also ADC, as we have heard before by Professor Usri, may be restricted, but it's not so uniform, and the enhancement is in most of the cases different because we have necrosis. And here is another case in which we may appreciate this characteristic of strong and homogeneous enhancement in this periventricular location, the T2 that is quite hypointense, most of all the ADC that is restricted, and as I told you before, we do not have to expect high CBV because the vessels are tiny, they are not so large to give a high value of CBV. Most importantly, if we look at the curves that we have to look at, this is from the DSC map, the curve doesn't reach the baseline due to the fact that we have a high permeability. And if we measure DCE perfusion, so T1 and K-trans, you may appreciate a higher K-trans and this curve that is a type 2 curve that relates to permeability. Then spectroscopies can show, as for other high-grade tumors, high raise in choline and a drop of creatine, but the most important feature may be the raise in lipid that you may appreciate more if you use TE at low value. So the structure, in most of the cases, the most typical one is that the one that I showed you, but you have to keep in mind that in a around 20–50%, the studies are not so numerous in the literature, you may find a dishomogeneous and appearance and the presence of hemorrhage. As you may see in this case, that is quite dishomogeneous in T2, and also the enhancement is quite strong. We have the edema, as I told you before. ADC is not so homogeneous as from the other example. And on your right side here, you may appreciate the presence also of tiny hemorrhages in SWI sequences, but enhancement in this other location is strong. Look on your right side, you have a case of a GBM where there is inhomogeneous appearance, presence of hemorrhage, and of course there is also a satellite lesion that explain you that you have in front of infiltrating tumors with different high-grade location. So regarding the presence of hemorrhage, there was a paper that highlighted in the differential diagnosis the absence of the tiny microbleeds in lymphoma, while they are commonly present in GBM. So this in general can be a sequence to look at in the differential diagnosis. Then there are the other aspects that I showed you before. Necrosis is not completely true that necrosis is not a characteristic of lymphoma of B cells lymphoma EB negative. You see here a case with a large center, necrotic center with a rim of enhancement, thick rim of enhancement. Again, you may appreciate that there is a low ADC here, so all the characteristics that we met before, and edema, and the absence of microbleeds in the SWI. On the lower row, you see a GBM. Of course, here we are more used to meet necrosis, but look at this case, we do not have microbleeds. And because of the large center of necrosis probably, and the ADC also is restricted. Then there are locations that are quite typical or that may tell you that you have to think about a primary central system lymphoma, B cells, and these are the more superficial location and leptomeningeal and subependymal. In this case, you see a lesion in the dorsolateral part of the brainstem and the medulla oblongata, and most of all, you all see again the enhancement. The enhancement is really superficial and is in some way ependymal, and you may appreciate it very well in the coronal way. So this kind of appearance, more superficial, and again, low ADC, enhancement is quite strong. And this is another case where you may see the spread in leptomeningeal spaces, like you see here, and you may have the affection of cranial nerves, and you may have the distribution in the ependymal, so periventricular one. This was thought to be a pattern of secondary lymphoma, so secondary location in the CNS by systemic lymphoma, as you may see here in the more spread subependymal distribution, but it's not. You may have it also in primary lymphoma. And another kind of location that is extra-axial, we may say, so more located in the ependymal places, may involve entirely the intraventricular system. And you may appreciate here a location in the third ventricle. And again, you can find the characteristic that I told you before. So ADC is low, the enhancement is quite homogeneous, and you see it in the other projection in sagittal and coronal. As I said before, in most of the cases it's single lesion, the primary central nervous system, but it may be multifocal also. And here is again another location of in the third ventricle and in the subarachnoid spaces, as you may see here. So three different locations, very similar. Usually they are very similar lesions. As I said before, this kind of lesion spread into the perivascular spaces, and you may try to look carefully at the lesion when you have problem in differential diagnosis. Again, you may have a suspicion here, but the lesion is quite dishomogeneous. Also, it is low ISO and low in T2. We have a very low ADC, a very strong enhancement, but look, one edema, and one thing that can help you in the diagnosis is this kind of spread through the perivascular spaces that can help you in diagnosis. Sometimes it may be difficult, and this is the reason why usually we recommend to go for delay imaging. Because look at this case. This was a very difficult case in an old patient in which flare showed you patchy, hyperintense involvement in the white matter that was quite difficult to understand and into the differential diagnosis of leukorrhiosis, for example. We can't see anything really in the ADC, but if we inject contrast and we go for delayed imaging, you may appreciate this punctate tiny enhancement that then was biopsied and appeared to be a diffuse B cells lymphoma, ABV negative, spreading into the perivascular spaces. And this has to be differentiated from this other entity that is included in the classification, that is the intravascular large B-cell lymphoma. It means that here there are tiny cells of lymphoma, that B cells that are into tiny vessels. This brings to the fact that you may have vascular lesion also, as you may appreciate here in the restricted diffusion, due to the occlusion of the vessels. In many cases, patients are older with dementia and cognitive decline, and if you go again with delayed imaging NT1, you may appreciate, again, very similar to the previous case, enhancement in the vessels and the perivascular vessels. And this is a very rare entity, but it exists. And so, looking back, just to summarize the enhancement, we may have different kind of pattern. So mass lesion that may be lower, deeper. It may be also a little bit dishomogeneous. It may spread through the ependymal and perivascular spaces, subarachnoid spaces, and here perivascular spaces in the centrum semivalley. As I told you before, the most important, one of the most tricky differential diagnoses we may have is with inflammatory lesions. And I'll show you here a case. Of course, it is more difficult for us to say when we are in front of younger patients. And even if, so the age has to be taken into account. So the older patients are more probably to harbor lymphoma, and inflammatory lesion, as we know, is more for young people. But sometimes it's really very difficult. Here is a case in which it was showed two different locations, two different lesions that were enhancing. You may appreciate here three different lesions. That one is quite edematous. There is enhancement, and the enhancement is quite irregular, and we could say that it goes through the perivascular spaces. Look at this case on the right side. This was resulted to be after biopsy as a localization of sarcoidosis. And at the beginning, what helped us in thinking about an inflammatory cases was the involvement of the dura. So this kind of, he came to the emergency room for an epileptic crisis. But it was clearly difficult. The hypothesis of a localization of lymphoma was proposed. This is another very difficult cases we met of an histiocytosis. It happened to be the result of the biopsy was Rosay-Dorfman disease. He had also lymphadenopathy in the cervical. Of course, here the young age, the brain involvement is quite rare. So you may see a lesion that is quite irregular in the profile, but the ADC is low. Look at the announcement, it's quite strong. It seems to go into the perivascular spaces. It's peripheral, as I showed you before for the lymphoma, and it has multiple localization. Regarding this differentiation, diagnostic differentiation, someone proposed to go for spectroscopy. Spectroscopy, as I showed you before, may show this in lymphoma, this peak of lipids. Better if you use low TE. But this peak of lipid, even if it seems to be lower, but it's difficult to have this kind of cutoff, it's present also in MS, for example, kind of lesions. Another point that I want to share with you is this description of the so-called sentinel lesion. This is important for the practical dealing in the practical life. Since it has been described that in some cases you may encounter this kind of lesion that may resemble inflammatory lesion. Of course, in a younger patient is easier. You may see here an enhancing lesion. Then in the throat, deep in location, so difficult to perform a biopsy. In the context, clinical context, they gave steroids. So they made the biopsy in this case, and the biopsy was not definitive, but more towards an inflammatory lesion, since it showed some demyelinating histology patterns. And after 2 years showed up to be a different lesion, more aggressive, and a second biopsy revealed the presence of a primary central system nervous lymphoma B cells. What has been described anatomopathologically, because this is a major problem for pathologists, is that in these kind of lesions that have been called sentinels, but probably not appropriately because it could be a lymphoma probably at the beginning, is that the use of steroid may alter the histology of the lesion. And if you look here in this comparison between these kind of so-called sentinel lesion and so the treated lymphoma and the inflammatory demyelinating lesions, there is a difference in the kind of diffuse demyelination, in the kind of involvement of the vessels, and the Ki-67 index that is higher for this sentinel. So some landmark of more aggressive lesions. And I want to show you another case that we had, and she was a young, very young lady, and appeared with this lesion, deep lesion in the temporal middle location with some characteristic, yes, probably you would say lymphoma in the origin, but they thought it could be an inflammatory lesion. So they gave corticosteroids, there was a clinical improvement, and after a few months later, another location came out, so they decided to make a biopsy. But at this moment, the diagnosis was not so conclusive, and they were thinking, due to the fact that there was inflammation cells, T cells, and some demyelination of a possible vasculitis of the central nervous system. But then a few months later, the lesion came out to be like that. We do not have a new biopsy, but it's not we may think that it was really a lymphoma in this case, and unfortunately the patient died. Another aspect that even if rare, but we have to take into consideration when we follow up this kind of patient, is that we may find after the treatment lesions that are not enhancing, probably because we do not look at the delay imaging, or we, in certain cases, I have to say that I double the contrast dose, and these are expressed as multiple area of hyperintensity in flare. And the proof that there possibly are, as I said in this paper, localization of lymphoma is that after the appropriate treatment, they disappeared. And with this kind of behavior, we may make a link with this quite rare picture of the so-called lymphomatosis, that it is more diffuse involvement of tiny cells into the interstitium and may give you this kind of picture of a multiple lesion in flare, some likes sort of edematous lesion, and you have to find the enhancement again going for delayed imaging. Just a few words on the EBV positive cases. The EBV positive cases are quite rare, and they are present in immunocompromised patients. The EBV is the herpes virus 4 that infect normal B cells and remain latent for the rest of the life. Of course, it comes up in immunocompromised patients. We are seeing a lot, we saw a lot in the HIV period. Now we see in transplant patients. And here, the landmark, the markers in diagnosis in MR are different because here, in the higher percentage of cases, we find necrosis, we find the hemorrhages, we find also a sign that is an hyperintense rim in the ADC and in the diffusion weighted images that has been described. So I just show you a case. We had several cases of this. The problem here is to make a differential diagnosis between infectious localization. This is a case of post-transplant and resulted to be a lymphoma with signs also of lymphoid granulomatosis. And you may appreciate here tiny lesion that resembles really very small abscess. This was really very difficult to say the difference, just to have in mind that in immunocompromised patients, we may have this kind of appearance. And as I showed you, there are more rarer cases of lymphoma that may spread in the dura. As you may see here, this is a localization of a multilymphoma in the CNS, and they usually appear with the old characteristic of the lymphoma, so ADC restriction and in the dura. Of course, here the differential diagnosis are other kind of pathology that may be located in the dura, like the EGG dura localization. So to sum up, conventional MR among the different sequences, diffusion is very important. SWI, look at it, because in most of the cases you do not have microbleeds, but take in mind that you may observe it. Regarding the so-called advanced MR, perfusion, yes, usually in comparison with GBM is not so high, but you have to have this cutoff, personal cutoff in your structure. Spectroscopy, look at the lipid, remembering that also in inflammatory lesion, you may have a raise in lipids. There are no conclusive data on FDG PET in the differential diagnosis, and we are still in the beginning for the application of AI and radiomics to say something conclusive. Here are a picture from a paper in which you may see that in radiomics there may be a feature or maybe a little bit different between the GBM and the lymphoma. And when they asked readers to make the differential diagnosis, the AI accuracy was higher, but this is just a study. And to close, the message is, of course, to make diagnosis of lymphoma, we have to go for biopsy nowadays to treat the patient. But, so this is an image of the pre-biopsy sequence after contrast, but just to tell you that there is a strong evidence that is up to 94% sensitivity and 98% specificity of the finding in CSF of a mutation double YD88 mutation and interleukin 10 in differentiating between PNS, PC, and SL from different CNS pathology, mostly GBM, but also MS and other inflammatory. And here is a graph in showing you the green line regarding this finding in the CSF. And there is a recommendation to go for this kind of test in the most difficult situation when you can't have the biopsy or it's difficult. So with that, I really thank you for your attention. Sorry if I went a little bit over, and with that, it would have been impossible to have all these cases without this kind of team that we have in our hospital between the lymphoma specified lymphoma unit, anatomopathology dedicated to lymphoma, and of course our collaborator. So thank you very much. I'm sorry for that.
Thank you very much.